Hello, hello everyone.
Hello, good afternoon.
Good afternoon. How are you doing all?
I'm good.
And how are your studies going?
It's going well, thank God.
All right. I think we should start, right?
Yes, 7 weeks.
Can you see my screen?
Yes,
Yes, sir, we can.
Okay. Yeah. All right. So, anyone who want to start?
I can go.
Mm-hmm.
Compared to a non-pregnant state, which of the following cardiac changes are most likely to be found in this patient? A 36-year-old woman, gravida 2, para 1, at 30 weeks gestation, comes to the office for a prenatal visit. The patient has noticed some ankle swelling at the end of the day that is relieved with elevating her legs, but she has no other concerns. The pregnancy has been uncomplicated, and her only medications are prenatal vitamin and iron supplement. The patient has no chronic medical conditions. She does not use tobacco or alcohol. Blood pressure is 118 by 78 and pulse is 72. BMI is 30. Fetal heart tones are normal. There is trace bilateral pedal edema to the shins. Physical examination is otherwise unremarkable. Urinalysis shows no protein. Compared to the non-pregnant state, which of the following cardiac changes are most likely to be found in this patient?
So, what do you think we have?
She has edema, and then it's because of the pregnancy, I guess.
Yeah.
So maybe they're asking the changes that would happen in a pregnant state.
Yeah. So, let's find out if we have any abnormalities or otherwise. So, we'll go as an a pregnancy changes. Okay. So, 36-year-old woman with gravida 2 para 1, 30 weeks of gestation, right? So third trimester, and she came to office for a prenatal visit. The patient has noticed an ankle swelling, right? At the end of a day that is relieved with elevating her legs, and she has no other concerns, right? So it can be due to pregnancy. Okay, the pregnancy is the pregnancy has been uncomplicated, and her only medications are prenatal vitamins and iron supplements. The patient has no chronic medical condition, does not use tobacco, alcohol, blood pressure is normal, pulse is normal, BMI is 30, fetal heart tones are normal. There is trace bilateral pedal edema. Physical examination is otherwise unremarkable. Urinalysis shows no protein, so she doesn't have any proteinuria or hypertension, right? Compared to a non-pregnant state, which of the following cardiac change is most likely to be found in this patient? So I think the whole stem, by going through the stem, uh, I think they are asking about the normal physiological changes in pregnancy, right? Because we don't have
Yes, sir.
any significant
yes,
pathologies, right?
yes.
Yes.
So I think that's easy concept about the changes in the changes of physiological changes in pregnancy, right?
Yes.
So what do you think we have? What are the normal physiological changes?
I
The
So
think
cardiac output would increase and the
let's
preload
start
would
from
increase.
blood volume, right?
okay.
So what do you think?
It will
Increase
increase.
Right? And we say
25% increase.
yeah, so 25 to some book says 30 to 40 or 50%, right? And the plasma volume increases more than the RBC mass, right? The plasma volume increases more than RBC mass increase, right? So
Yes.
we call this as a physiological anemia of pregnancy, right? So first thing we know about is blood volume increase, right? And why the blood volume is increased?
To
Because
fulfill
of
the
increased plasma volume.
demand,
Sorry, because we have increased metabolic demands, right? Metabolic
Yes.
demands of uterus and fetus, right? Uterus and fetus, right? And also the increased blood volume makes the patient safer during the blood loss and delivery, right? So what do you think the blood increase in blood volume will do to cardiac output?
It would increase.
Yeah, so mm, cardiac output is increased, right?
Hmm.
And so this is, I think,
It should
uh,
be preload. Mm.
so this is preload and this is afterload. Okay, so it's a mistake over here. Okay, so what do you think about preload? What happens to the
Preload would
preload?
increase.
increase.
What do you think?
Preload is
Increase.
increased because blood volume is increasing.
Okay, so it's easy, right?
Yes.
And what about the afterload?
That would decrease.
Why?
EPR is decreasing.
Sorry.
Because
Inversely
of
proportional.
Yeah. So we have SVR or we can say TPR is decreased, right? And what are the reason behind the decreased in peripheral resistance or vascular resistance?
Because of the progesterone on the
Yeah.
vascular
So we
vessels.
have hormonal effects, right? So progesterone, estrogen, nitric oxide, they all released, and pregnancy leading to decreased systemic vascular resistance, right? And what's the other reason? Anyone? What's the other reason for decrease in SVR?
Compression
Because,
of gravid uterus.
like, let me give you a clue. Like, we have placental flow, right? Which was not there before. So we call it formation of high flow, low resistance placental circulation. Okay. So we have an extra path to the flow of blood, right? Which has low resistance. Okay. All right. So we have an extra. Are you guys getting my point?
Yes.
I think somebody opened her mic and is reading.
Yeah, I think she is late.
Can you
So
please mute your mic?
let me see who is talking. Yeah, so the SVR is decreased, and just from the blood volumes, you can say cardiac output is increased and venous return is increased, right? And why the blood volume is decreased to met the increase oxygen demands like from the uterus and fetus, right? All right.
Yes.
So I think in repro section of the first aid, you will have a table of the physiological changes in pregnancy. So go through that, and I will share the image of that in a group as well. Okay. So just for summary, you can go through all these. Okay. Yeah. Anyone?
Can I go?
Yes, please.
Occlusion of which of the following coronary arteries is most likely responsible for this patient's symptoms? A
Mhm.
59-year-old African American male present to emergency room with a crushing chest pain, sweating, and lightheadedness. His blood pressure is 90 over 60 and his heart rate is 48 beats per minute. ECG shows sinus bradycardia and ST segment elevation in lead 2, 3, and AVF. Which of the following coronary arteries is most likely responsible for this patient's symptoms? It's the
Yeah.
inferior wall MI.
Yeah, but I have forgot the one point of about edema, right? In previous question. So why did she had edema? And she was pregnant of 30 weeks, right?
Because
Because
of
of
the gravid uterus can
Yeah,
be or
because of the yeah. So the due to the increased venous pressure in lower limbs, right?
Yes, sir.
From the uterine compression of inferior vena cava. Okay. All right.
yes,
Yeah. So now on the second question, what do we have?
MI,
We have inferior lead. Am I right?
yes,
And we have discussed it that lead 2, 3, and AVF suggest inferior lead MI. And we also have discussed the coronary supply to the inferior surface of the heart, right? Which is PDA, right?
yeah,
And
posterior
it's a
descent,
branch of right
right
coronary
coronary.
artery. Is it clear or we should discuss it? I think we have or done almost 40 questions on anatomy and we have discussed it in great details, right?
Yes,
The
Yes,
sir.
coordinate supply, right? And it's easy if you go through it. So not that much of explanation is needed, okay? So which option?
D, right coronary artery.
D. Okay. So yeah, we have discussed all these, right?
Can we just go through it again? Some of us just join not quite long.
Yeah, so just remind me at the end if we had time, okay? And I will discuss the coronary supply again, okay? And also we had you can watch the videos if you can, okay? So in first day of the lectures, day one of the cardiology, we have discussed the coronary supply and ECG leads in some detail, okay? All right, because today we have like the questions times are a big long, so
Yeah, it
it
sounds
will take
good. We
time,
can
okay?
do it later, or we can
Okay.
see the videos.
Okay, thank you. Yeah, anyone? So the first two questions were easy, and now we will be discussing the congenital abnormalities, okay?
I can go again.
Yes.
Which
I
of the
can go.
following is the most likely diagnosis? Do you want to?
Mm-hmm.
Oh, you can go, Sarah, if you want.
Okay, thank you. Which of the following is most likely diagnosis? A 10-year-old boy who recently immigrated from overseas with his family is brought to the office due to exertional dyspnea and fatigability. The boy tires easily when walking and cannot keep up with his peers at the playground. Sorry. According to his parents, he was diagnosed with congenital heart disease in infancy, but corrective treatment was unavailable. They
Mhm.
cannot recall the details of his diagnosis. He takes a daily multivitamin and no medication. Pulse
Mhm.
oximetry shows 98% in the right hand and 84% in the right foot. Physical examination reveals no murmurs. There is bilateral cyanosis and clubbing of toes. The hands and fingers appear normal. All extremity pulses are equal and full. Which of the
Mhm.
following is most likely diagnosis?
So can you summarize this, Tam?
So basically, it's a 10-year-old boy, and the
Mm-hmm.
problem is like cyanosis, and the pulse oximetry shows like 98% right hand and less in 84% in the right foot, and
Mm-hmm.
no murmur, cyanosis, and clubbing. And
Mm-hmm.
yeah, so this is the main problem.
So
And tires easily, so cannot keep up with his peers.
yeah, so the cyanosis or the mixing of the deoxygenated blood can be the cause of easy fatigability, right? So we have a 10-year-old boy, and he was diagnosed with congenital heart disease, but they didn't know. So let's find out. So we have given a the pulse oximetry. So the oxygen saturation in the upper limbs is normal, right? While in the lower limb it is decreased. So we call it. Uh, so what do you think? Which condition leads to the differential or the different type of oxygen saturation?
PDA.
Yeah. So what happens in PDA? That we had a shunt between the aorta and pulmonary artery, right? So
Yeah.
when the shunt is from pulmonary artery to aorta, so we will see the cyanosis, right? From right to left. Is it clear? And I will discuss the right to left shunt and left to right shunt in detail, okay? So why does we have the like in the upper extremities, the oxygen saturation is normal, and the in the lower extremities, the oxygen saturation is different.
It's depend on the location of the shunt. Either
Anyone
it's
knows?
like
Yeah, if the location of the shunt is towards the
Do you
descending
guys
aorta.
remember we had discussed first one is brachiocephalic artery, right? The second is common carotid, and the last is subclavian, right? And the patent ductus arteriosus is over here, right? Are you guys with me?
yes.
So this is where the patent ductus arteriosus is. So if this is pulmonary artery, okay, and so all this supply from heart to till subclavian artery, this supply the oxygen saturation till here will be normal, right? And from here down we have descending aorta, right? And the blood is mixing after the subclavian artery, right? Are you guys confused? Hello?
We are getting you, sir.
But you are so
Yeah, we get
silent.
it.
You
We
guys are
get
so
it.
silent, okay? So be with me. So the descending aorta, we will have mixing of blood, right? And the deoxygenated blood from the pulmonary artery is going into aorta, leading to decreased oxygen saturation, okay? All right?
Yes, sir.
Yeah.
So, what do you think the right to left shunts are? Sorry, the yeah, let's start with the right to left shunts. What are the right to left shunts?
Blood from the right side of the heart going to the left side of the heart or
So,
vessels.
yeah, and would you see cyanosis in right to left shunt or left to right?
Right to
Right
left.
to left.
Yeah, easy, right? So we have this is right heart and this is left. So whenever the blood is mixing from right to left, so we call it this is venous blood, right? This is venous blood, and this is oxygenated, or we can say arterial blood. Okay, from here aorta is going out. So from so what do you think the PDA is? Left to right or right to left shunt?
Right to left.
So initially it's from left to right, okay? The blood is going from aorta to pulmonary artery, okay? And we say there won't be any cyanosis, okay? Right?
Yeah.
But we know in Eisenmenger syndrome, the shunts reverse, okay? So first, normally it's like this, okay? Then it becomes the opposite way, okay? And then you will have the cyanosis, all right?
All right.
And why do we have shunt reversal? What's the reason behind it? I think you guys are so much confused about.
Increase in pressure
Yeah, so
from the vessel.
like in left to right shunts, we say we don't have cyanosis, right? Or we can say the cyanoses are late, right? Why the cyanoses are late? Because, and what are the example of left to right shunts? ASD, VSD, and PDA. Okay, all right.
Yes, sir.
But due to Eisenmenger syndrome, what happens is when we have left to right shunt, let's say we have VSD, okay? In case of VSD, if we have left to right shunt, so the right ventricular volume increase, right?
Yes.
And we have increased flow through pulmonary artery, right? And same for the PDA. So if this is pulmonary artery and this is aorta, so we have increased blood flow in pulmonary artery, okay? And this increase in blood flow leads to vascular remodeling, okay? Vascular remodeling, leading to increased pressures in pulmonary artery, which leads to the reversal of shunts, okay? Also in VSD, we have ventricular hypertrophy, which leads to the reversal of the shunts, okay? All right.
Okay.
I have a question, sir.
Mm-hmm.
Why is there no murmur?
Sorry.
Why is there no murmur from the physical examination?
And so, what type of murmur we have in the PDA?
Machine-like
Mention
murmur.
like
Keen like murmur.
Machine-like murmurs, right? So
Yeah.
sometimes we don't hear murmur I don't know what's
But they
the.
said in the question
Yeah.
like he was treated maybe, but the corrective surgery was unavailable. Like now he's 10 year old now, but he was diagnosed it in infancy, so maybe he went through some surgery.
No, it's not
Hmm?
about the surgery. They have said like we have decreased transductal pressure gradient. That's why we don't have the murmurs. But I will check it out, okay?
Okay,
So
sir.
if there is, okay.
They have said, if anyone knows, they are saying that the murmurs may disappear due to lower transductal pressure gradient.
Okay.
All right. So we have our diagnosis is PDA, right?
Yes.
You can see it over here. The upper limb supply is, so before this, the oxygen saturation is normal, okay?
Yeah.
And in descending aorta, the oxygen saturation
Going
become
down.
affected, okay? So this is like the differential cyanosis is a high yield point for PDA, okay? All right.
Yes, sir.
Okay, anyone?
Which of the following the patient condition is most likely associated with which of the following genetic conditions? A 5 week old boy is being evaluated for a week long history of rapid breathing and tiring with the feet. The infant was born at home after an uneventful pregnancy. The mother declined all prenatal testing and ultrasound evaluation. His temperature is 36.7, blood pressure is 76 over 38, pulse is 124 per minute, respiration 66 per minute. The patient cardiovascular examination is notable for a hyperdynamic precordium and a mid-diastolic rumble at the left sternal border, and 3 by 6 hollow systolic murmur in the neck in the apex that radiate to the left axilla. Echocardiogram showed defect in the lower part of the interarterial septum and interventricular septum. The patient
Mhm.
condition is most likely associated with which of the following genetic condition?
So I think they have given you almost all the clues, right?
Is
Can you
regurg?
can you summarize it?
Yeah, it's a 5 week old boy
Mm-hmm.
delivered through normal vaginal delivery, but the mother don't have any like prenatal testing and ultrasound reports. And
So
now
we don't know whether the condition is genetic or not, okay?
yes,
Mm-hmm.
and the BP is 76 over 38, and his pulse is 124, and respiration is 66. On physical examination, there is like a hyperdynamic precordium,
Mm-hmm.
mid-systolic rumble at the left sternal border.
Mm-hmm.
And they did the grading 3 by 6 hollow systolic murmur at the apex, but it's radiating towards the left axilla. So
Mm-hmm.
it's mean it's a mitral. And
Yeah.
echocardiogram show.
Mm-hmm. Yeah, this is important. Echo shows.
Yeah, so on echo, they show that the defect is in the lower part of the interarterial septum and interventricular septum.
Yeah.
And this, the patient condition is most likely associated with which of the following genetic condition?
So let's start from the echo, which can be explained easily, right? So we have a defect in the lower part of the interatrial septum, right?
Yes,
So ASD, right?
yes.
Like type is mm, primum, right? Not secundum, right? So we have ASD, also inter defect in interventricular septum, right? So we also
Yeah,
have
VSD. VSD.
VSD, right? And Now come to the murmur. So we have a diastolic rumble and hollow systolic murmur that radiates to axilla, right? So it's a mitral regurg,
Research.
right? Are you confused about mitral regurg?
So, sir, it could be tricuspid regurg too, or no? Because both goes to the axilla, because both radiates to axilla.
Yeah, but when you have such things like congenital anomalies, and they are talking about the murmurs that are radiating to axilla, so you should be more concerned about the left side heart, okay? And what do you think the difference between the tricuspid regurg and mitral regurg is?
So, mitral
What
regurg,
do you
it is.
think tricuspid regurg sound is? How does that sound is?
This hyperdynamic circulation is because of this mitral regurg.
Yeah, it can be a point, but what's the tricuspid regurg sound?
I don't know, sir.
So let me discuss the sounds and murmurs, okay?
Okay, thank you.
So it will take some time, but yeah, we will discuss it, okay? Give me a second. So I have made some notes in mnemonics. All right. Sorry, guys, give me a second. All right, okay. So, so we have discussed all these high yield points if you remember the yesterday class. Can you guys hear me?
Yes.
Okay. So we have two type of murmurs, right? Systolic and diastolic. So be with me, okay? So it should be like an interactive session, okay?
Yes,
All right.
sir.
So we have two type of murmurs, systolic and diastolic, right?
Yes, sir.
And yesterday I have told you the easiest thing to memorize what are the systolic and what are the diastolic sounds, right? So just make the arrows in upward area or the upper area like upwards and the lower area in downwards, okay? So now you can guess it from this sketch. Tell me what's this in systole?
Mitral regurgitation.
Yeah, and because when we have when we have systole and the ventricle is contracting, right? The pressure the pressure is upwards, right? And on this valve, the tricuspid valve, the pressure is downward, right?
Yes, sir.
So when we have aortic stenosis, so it can be heard during systole, okay? Or if we have a mitral regurg, okay? So mitral regurg and aortic stenosis, they are systolic murmurs, okay? All right.
Yes, sir.
And same over here. So if we have So if we have mitral regurg, so on this side we have
Tricuspid regurg.
tricuspid regurg, and aortic stenosis as well as pulmonic
Steno.
stenosis. Okay. Sorry, guys. The thing is not doing well today. Okay. Yeah. So, and what about diastole? So diastole is opposite. Okay. If the ventricle is relaxing, if the ventricle is relaxing, so we will hear the sounds opposite to that. Okay. So tell me what it can be. Mitral stenosis, right? And also tricuspid stenosis. Okay. Tricuspid regurg, right? So when the ventricles are relaxing, so the aortic flow will be doing backwards, right?
Yes, sir.
So tricuspid regurg and pulmonic regurg. So remember, just remember the systole
Is it
and just
tricuspid regurg or tricuspid regurg or aortic regurg?
Aortic. Aortic.
sorry. Okay, so just remember this graph is like we have drawn it. Okay, so this is for systole. Okay, so along with the these four, we also have hypertrophic cardiomyopathy and VSD. Okay, so these six sounds will be systolic. Okay, mitral regurg, tricuspid regurg, aortic stenosis, pulmonic stenosis, hypertrophic cardiomyopathy, and VSD. All these will be given as systolic murmurs. Okay, got
Yes,
this?
sir. Yes, sir.
Now we also have discussed yesterday that we have areas A, P, T, M, right?
Yes.
Now, tell me, what was your question? What was your
So my
question?
question was that, like,
Mhm.
how do we know that it is a mitral
Tricuspid.
regurgitation murmur or tricuspid? Because
So
both radiate to axilla.
yeah, both radiates to axilla, right? And the
Yes.
murmur was at apex, and the tricuspid regurg is at left lower sternal border.
Sternal cord. Okay.
All right.
Yes.
So if they have given you the murmur is at apex and radiating to axilla, so definitely it is mitral
Mitral. Yeah. Got it.
regurg,
Okay.
right? So
Yes.
just for shorter revision, we have aortic stenosis here, right? In
Yes.
like second, and fifth, okay?
Yeah. Yeah.
And here we have left sternal border, okay? This is right upper, left sternum, and left lower, right? And apex, right?
Yes.
So remember the location. The locations are very important. You can get the question very easily from the locations, okay? All right.
Yes, sir.
What about
Can you
the...
repeat
Mhm.
systolic murmurs, please? Can you repeat them?
Sorry?
Can you repeat the systolic murmurs?
Yeah, so we had systolic murmurs, okay? And I have given a hint, like make a sketch like this of a heart, and the upper section, the arrow should be going up, and the lower section, the arrow should be going down. So this is for mitral regurg, okay? And this is for aortic stenosis, okay? And same stenosis here and regurg or here, okay? Also, hypertrophic cardiomyopathy and VSD will be systolic, okay? All right. Now, the mnemonic is in APTM. We have said that here at the tricuspid area, we also hear VSD, right? From mnemonic TV, right?
Yes, sir.
Okay, and what else we have at the pulmonary area, in the pulmonic area?
PDA?
Mm-hmm. PDA and ASD, right?
Yes, sir.
So why the ASD is heard over here? Because the ASD itself does not cause any sound. Okay, so if this is in ASD, right? If this is in ASD, so this area does not cause sound by itself. Rather, the flow from right to left goes through the pulmonary circulation and causes the increase in pulmonic flow. Okay, all right. And this increase in the pulmonic flow is heard over pulmonary area. Okay, so now you have remembered that first we have systolic heart sounds and diastolic heart sounds, right? The second thing we remembered is the borders, right upper, left lower sternal border, and the apex. Okay, so whenever you have a question, just first go through the location and then check out if it's diastolic or systolic. Okay, all
Yes,
right.
sir. Yes, sir.
All right, so yeah, I will discuss the heart sounds in detail in a while as well. Okay, so we'll discuss the heart sounds more. Okay, now come to the question, what do we have? We have ASD, we have VSD, and we have mitral regurg. Okay, is it
So,
clear?
so but we
Yes,
just
sir.
learned that mitral regurg is systolic, but the question is saying it's mid diastolic rumble.
No, don't. Yeah, so they are saying hollow systolic murmur that radiates to apex.
Okay.
So I am not going in detail of the mid diastolic and
Okay.
all the
Okay.
details because we have like three abnormalities. Okay, we have ASD, VSD, and mitral regurg. Okay,
Got it. Got it. Yes, sir. Thank you,
so the
sir.
hollow systolic murmur is saying about, they are saying about is mitral regurg. Okay,
Yes,
so
sir.
so what do you think VSD sound is?
Holosystolic.
Yeah, so VSD and mitral regurg, the sounds will be same. So VSD, mitral regurg, and tricuspid regurg, all three have same sounds. Okay,
Yes, sir.
just the locations are different.
Different.
Okay, all right. Yeah, so what do you think your diagnosis is? What's the
VSD and
condition where,
ASD would be in Downs.
Down syndrome.
yeah, Down syndrome can lead to this, but all the three conditions occur simultaneously in endocardial Cushing defect, right?
Right.
So all these three occurring in is a endocardial Cushing defect. Okay, and this is most common in Down syndrome, right?
Right.
And Down syndrome is
Autosomal
monosomy or
trisomy.
trisomy?
Trisomy.
Trisomy.
Trisomy,
Trisomy
right?
21.
So I thought the question is easy, but yeah, what about the DJOG
That
syndrome?
is DeGeorge.
De George.
Yeah, so what do you see in DJOG syndrome?
The
Cardiac
thymic
abnormalities.
Thymic aplasia.
studies, yeah.
The cardiac abnormalities. So you will see tetralogy of Fallot, truncus arteriosus, okay, and transposition of great vessels, okay. All right. So these these three conditions are common in Dijok syndrome. Okay. Trisomy, we have discussed, is a Down syndrome. You will see endocardial Cushing defects. Okay. And endocardial Cushing defects, they are ASD, VSD, and valve effect. Okay. Like mitral regurg. All right. Guys, are you with me?
Yes, yes.
And
Yes.
what about the fibrillin mutation?
That is Marfan's.
Yeah, and Marfan's, it is associated with aortic,
Aortic dissection,
yeah,
aortic
aortic
aneurysm.
root dilatation.
Mitral valve prolapse.
Aortic root dilatation leads to aneurysm and dissection. Okay, all right, and plus mitral valve prolapse. So remember the two: aortic root dilatation. Aortic root dilatation leads to aneurysm, and that aneurysm can causes aortic dissection, and we have mitral valve prolapse. Okay, frataxin gene is for Friedreich
Frederick
ataxia,
ataxia.
and it's not related to cardiac abnormalities. Okay, what about the Hamarton gene?
Tuberous sclerosis.
And you will see tumors, cardiac tumors. Okay, and tuberous sclerosis, you will see cardiac tumors. What about monosomy?
Turner syndrome.
Monosomy Turner.
Turners, right? And what do you see in Turners?
Bicuspid aortic valve.
Yeah, so
Coarctation of aorta. Coarctation
Turners
of
is
aorta.
associated with aorta. Okay, so one of them is coarctation and bicuspid aorta. Okay, all right, all
Yes,
right.
sir.
Okay.
Yes,
Yes,
sir.
yes, yes.
We can move forward.
Mhm. Yeah, so the option is B, right?
B. B.
Okay, anyone?
Sir, could you please tell me which day of the serial schedule is today's class? The IDs are not matching.
Sorry,
Could you please tell me which day of the serial schedule is today's class?
I I don't get your question because
She's
you have.
asking that which day is it according to the CVS schedule?
So it's fourth day, right?
Yes, sir.
Yeah, it's fourth day.
Yes.
Okay. Yeah. So anyone?
I can go. This
Mm-hmm.
patient's findings are likely due to which of the following embryologic events? A 1 week old brought to the office for his first primary care following an uncomplicated vaginal delivery at 40 weeks gestation. The patient was born to a 30-year-old woman who took prenatal vitamins throughout the pregnancy. The nursery course was uncomplicated and he was discharged at approximately 30 hours of life following observation of appropriate breastfeeding, voiding, and stooling.
Mm-hmm.
Weight, length, and head circumference are the 50th percentile. Physical examination shows a grade 2, 6 harsh hollow systolic murmur, best heard at the left mid, left lower sternal border. The rest of the examination is unremarkable. Review of medical records show absence of the murmur at birth. The patient's findings are most likely due to which of the following embryologic events?
So, what do you think we have? So, a hollow systolic murmur, best heard it left lower.
BSD?
So, it left lower sternal border, yeah, left lower sternal border. It is an area of tricuspid area, right?
Yes, sir.
And I have given you the mnemonic is in TV, okay? All right. And the murmur is hollow systolic murmur, right?
So it's a VSD.
So, and what about tricuspid regurg? It's also hollow systolic, but it's more of a blowing murmur. Okay, so let's confirm the diagnosis from the other sign and symptoms. Okay, all right. So we have a 1 week old boy is brought to office for the 1 week old boy is brought to office for the primary care visit in an uncomplicated vaginal delivery at 40 week gestation. The patient was born to a 30-year-old woman who took prenatal vitamins throughout the pregnancy. Okay, the nursery course was uncomplicated and he was discharged at approximately 30 hours of life following observation and appropriate breastfeeding, voiding, and stooling. So till now we have no abnormalities. Weight, length, and head circumference are 50th percentile. Physical examination shows harsh, hollow systolic murmur. Okay, best heard at the left mid to left lower sternal border. The rest of examination is unremarkable. Review of medical record shows absence of murmur at birth. Right. These findings are most likely due to the which of the following embryological event. So, what do you think the diagnosis is? We have
VSD.
VSD, right? And which type of shunt is VSD?
Right or left?
Left to
Left to
right.
right.
Left to
Left to
right.
Left
right.
to right.
So
No
remember
cyanosis
ASD,
until Eisenmenger.
ASD, yeah, ASD, VSD, and PDA. They are left to right. Okay, with no cyanosis. Okay.
Okay.
Insufficient development of the interventricular septum?
Yeah, so it's easy, right?
Yes.
Yeah.
Insufficient development of interventricular septum. Okay. What about the septum secundum? What are they talking it about?
Could be
ASD.
behavior?
ASD,
VSD.
right?
Oh.
Secundum type, right? And failed fusion between septum primum and endocardial cushions.
Is ASD.
Yeah, so they that's also septum primum and endocardial cushion. So this is secundum, right? And this is ASD primum, right? Ostium primum. All right. And endocardial cushions, what defects can be there?
ASD, VSD.
ASD, VSD, and mitral regurg, right?
Yes, sir.
And what about the option E, infundibular septum? So the septum is related to conotruncal abnormalities, okay? Just like is tetralogy of Fallot and transposition of great vessels, okay?
Yes, sir.
So how did you diagnose the VSD?
Because of the nature of the murmur and its site.
Yeah, so first thing is site, okay? Second is nature of the murmur, and the murmur was not present at birth, okay? The murmur was absent at birth, right? When we have decreased pulmonary vascular resistance, right? So the murmur is now audible. Is it clear? Normally, if we have VSD, right, in utero, can you hear the VSD in utero?
No.
No, sir.
No, because we don't have flow over here, right?
Yes, sir.
So you will only hear if they are present in utero, so it can be tricuspid, okay? Because we are hearing it left lower sternal border, right? Is it clear? Why are you guys so much silent? I am not enjoying the
Yes,
class today.
doctor, it's clear. It's clear.
I
I
am not
think
enjoying.
everyone are
Mhm.
taking time to process it, sir.
But they are not that much difficult. If we like, if I am going in detail of why the murmur is like this and that, so the murmurs are like in large number, and you won't be able to retain that concept that why some murmurs are like this and some other are like that. The important thing is that you should know whether the murmurs are systolic and diastolic or diastolic, and whether from where the murmurs are heard easily, right? So
Yes.
the point is the point I'm making is you should memorize the murmurs, okay? All right.
Yeah.
can
Yes.
Yes.
we can we move on?
Yes,
Oh.
yes,
Yes.
please.
Because today all the questions, most of the questions are from congenital abnormality, so you will be seeing the murmurs and its embryo, okay? All right. Yeah, so they have given you all the murmurs, which one is crescendo, decrescendo. So I will discuss some of it, okay? Yeah, anyone?
Which of the following is the most likely cause of this patient's murmur? A 16-year-old boy is evaluated in the office due to leg cramps. He plays
Mm-hmm.
soccer but frequently stops in the middle of practice due to cramps in both legs. The patient is afebrile. Blood pressure is 170 over 90 bilaterally in the upper extremities. The point of maximal impulse is non displaced. S1 is present and S2 is physiologically split and S4 is heard as well as a continuous murmur best auscultated over the back at the left intrascapular area. There is no appreciable murmur on auscultation of the anterior chest. Distal pulses in the radial arteries are prominent. Dorsal pedalis uh, dorsal pedis and posterior tibial pulses are difficult to palpate. The rest of the physical examination is unremarkable. Which of the following is most likely cause of this patient's murmur?
So we have a 16-year-old boy. The problem he had is leg cramps, right? In both legs. The patient is afebrile. The blood pressure in the upper extremities is 170 over 90, okay? S1 is present, S2 is physiologically split, and S4 is heard. As well as a continuous murmur best auscultated the back of the the back at the left interscapular area. There is no appreciable murmur on the auscultation of the anterior chest, right? Distal pulses in the radial artery are prominent. So radial pulses are prominent. Radial pulses are prominent, while the dorsal and the dorsalis pedis and posterior tibial pulses are difficult to palpate. The rest of the physical examination is unremarkable. Which of the following is most likely the cause of this patient? So, what are the findings we have?
PDF
There,
finding.
There is
So
difference
start
between.
from start from the things we already know from the previous lectures. Okay, so it will be the question will be easy. Okay,
Yes,
so
sir.
S for left ventricular.
Hypertrophy.
So one thing is he had left ventricular hypertrophy. Okay,
Yes, sir.
what else?
There is difference between upper and lower extremity pulses.
Yeah, so we call it brachiofemoral
Delay.
delay, right?
Yes, sir.
What else? So he had leg cramps. So maybe it is due to decreased blood flow to the lower limbs, right?
So,
And what about the murmur? A continuous murmur best auscultated over the back, right? At
yes,
the
sir.
left interscapular area. So what do you think your diagnosis is? Because they have excluded all the murmurs of the anterior chest,
Coarctation of aorta.
Aorta. Yeah.
right?
Yeah.
So we have coarctation of aorta. And what are they asking about? Which of the following is most likely the cause of this patient murmur?
B. Increased blood flow through collateral blood vessels.
Yeah, so you know that in coarctation of aorta, we have collateral vessels formation. So let me show you the vessels formation. Yeah, so they have given you the points that we have increased blood pressure and strong pulses in the upper extremities, decreased blood pressure and weak pulses in the lower extremities, right? So we call it, we call this is brachiofemoral delay, right?
Yes, sir.
The patient has upper extremity hypertension with diminished lower extremity pulses. These findings are consistent with coarctation of aorta, right? Yeah, so we have a picture. You can see over here that due to narrowing of the aorta, or we can say a coarctation of aorta, we have the formation of collaterals, right? And these collaterals is responsible for forming
Murmur.
murmur, right?
Yes, sir.
So it's clear
Yes, sir.
because
Clear.
we have excluded the tricuspid valve, pulmonary valve, ductus arteriosus, all these murmurs we hear it is on the anterior chest wall, right?
Yes.
And there is no appreciable murmur on the auscultation of anterior chest. Okay, so remember the high yield point we have is continuous murmur, best auscultated over the back. Okay, all right. And why do we have the brachiofemoral delay? So same like PDA, where we had the mixing of blood in the descending aorta, right? In PDA, we had mixing of blood in descending aorta, and that's why we have cyanosis in lower extremities, right? The same thing over here is that we have coarctation of aortic narrowing, right? So before the narrowing, the blood supply is normal, okay? The blood supply is okay, right? So after the narrowing, we will have decreased circulation, okay? All right.
Yes.
Yeah, anyone?
Which of the following pathological findings in the kidney is most correlated with this patient's acute condition? This is about renal. Should we do
Yeah,
it?
so oh, no. I
Oh,
think I
okay.
have to skip this one and this one as well, okay? It's about hyperparathyroidism.
This is
Okay.
endocrine. No?
Yeah. So
Okay.
let's do question number 9, okay?
Okay. The structural changes observed in this patient's heart are most likely associated with which of the following conditions? A
Mm-hmm.
56-year-old man is admitted to a tertiary care center after being involved in a high-speed motor vehicle accident. The patient was thrown from his vehicle and suffered severe head trauma along with multiple fractures involving
Mm-hmm.
his ribs and extremities. Despite aggressive treatment, he dies the following day from massive cerebral edema and brain stem herniation.
Mm-hmm.
Autopsy shows the following heart findings: left atrium is enlarged, left ventricular myocardial mass is increased, left ventricular wall thickness is increased. The structural changes observed in this patient's heart are most likely associated with which of the following conditions?
So what do you think we have?
Long-standing hypertension.
Yeah. So the first thing is we have an RTA, right? The patient was the patient was thrown from his vehicle, suffered severe head trauma, along with multiple fractures involving ribs and extremities. Despite aggressive treatment, he dies because of the massive cerebral edema and brain stem herniation. Autopsy. So from here to here, we don't have any important clue about the heart. Autopsy shows the following heart findings. So the left atria is enlarged, right?
Yeah.
Left atria is enlarged. Left ventricular myocardial mass is increased, and left ventricular wall thickness is also increased. So, what do you think? Which type of hypertrophy it is? We have discussed type of hypertrophies
Concentric.
yesterday. Is it
Concentric.
concentric? Is it
Concentric.
concentric
Concentric.
or yeah? So we have concentric hypertrophy, right? Because the thickness is
Holistic.
increased. I have told you PCT. Due to increase in pressure, we have concentric hypertrophy that is leading to increased thickness of the
Ventricular wall muscle.
ventricular wall muscles. And from this, you can understand is increased pressures are responsible for it, right?
Yes, sir.
Yes.
So can ASD leads to concentric hypertrophy?
No.
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 So what do you think ASD have? I have told you ASD is which type of shunt?
Left to right.
Left to
Left to
right.
right shunt, right?
Yes, I
So what will
noted.
happen? What will happen when we have increased flow to right side of the heart? Volume overload, right?
Yes, sir.
And volume overload leads to
Eccentric type of.
Eccentric.
eccentric. Yeah. So it ASD can cause eccentric hypertrophy. Okay. The long-standing hypertension. So yeah, increase pressures or work of the heart against the increased pressure can lead to concentric hypertrophy. Okay. What about the mitral insufficiency? What do you think mitral insufficiency will lead?
Oh gosh.
Like if we have mitral insufficiency, so it will affect the left ventricular volume, right? Right?
Yeah.
So again, not the pressures, okay?
Yes, sir.
So increase in left ventricular volume will lead to again the eccentric hypertrophy, okay? And we had a question on the mitral stenosis yesterday. Mitral stenosis leads to left atrial enlargement, right?
Yes, sir.
And the left ventricle was
Normal.
normal, right? And we also had discussed the aging effect, and we had a sigmoid
Shape. Ventricular.
shape ventricular hypertrophy, right? And
Yes.
the age of the patient is 56. And this type of hypertrophy, you will see it in the 70s, okay? All right.
Sir, can you please draw which one the sigmoid shape?
Sorry.
Can you please repeat the sigmoid shape atrophy, hypertrophy?
Yeah. So in aging, the hypertrophy, the heart muscle hypertrophy is type of sigmoid shape, okay?
Okay.
And what about the myocardial infarction?
There will be hypokinesis.
Yeah, hypokinesis, which leads to volume
Of
overload, right? So
sir.
again, it can lead to is in eccentric hypertrophy. If you go back to the slides of the eccentric and concentric, you will see the causes of both the conditions. Okay, so all the causes we are discussing were already discussed yesterday. Okay,
Yes, sir.
and in Wolf Parkinson syndrome, we have tachyarrhythmias. Okay, and normal left ventricle. Okay, so we don't have any increase or decrease in size of left ventricle in Wolf Parkinson. Okay,
Yes, sir.
so the question is easy because they have given you the clue, which is left ventricular thickness is increased, myocardial mass is increased, and left atrial size is increased. Okay, and the reason, so we have diagnosed is a concentric hypertrophy. Okay, and the reason or the cause of the concentric hypertrophy is pressure. Okay, which is long-standing hypertension. Okay,
Yes, sir.
it also can be aortic stenosis. All right, what else can lead to concentric hypertrophy? Strength training, we have discussed it, right?
Yes.
So long-standing hypertension, aortic stenosis, strength training, all these can lead to concentric hypertrophy. Okay,
So it can also be genetic mutation also, right?
like
I'm not sure. So that's why I was asking. We can come back to it later, so it's okay. We can continue.
okay, no problem.
What about
So
Hokum? Hokum.
cause left atrial dilation also, right?
Mm-hmm.
Because there's left atrial enlargement here.
Yeah, so the left atrial enlargement is because of the hypertrophy, like when we have normal concentric hypertrophy in athletes, so it does not lead to left atrial enlargement. Okay, but when the condition becomes severe, so it can lead to left atrial enlargement, pulmonary edema, and left heart failure. Okay.
Yeah. So how do we differentiate, sir? Like it's not mitral stenosis versus
Yeah, so
uh,
yeah, so we have discussed the mitral stenosis yesterday. The mitral stenosis only in mitral stenosis only the left atria enlargement occur, okay, and the left ventricle is normal. Here we have increased left ventricular mass and thickness, okay. So in mitral stenosis only the left atria is affected. Okay.
Okay, okay, got it. Thank you, sir.
And is volume overload, right? In case of mitral stenosis, not the pressure.
Yeah, but
Right.
the pressure that only effect is the pressure effect is only on left atria. Okay, which also leads to volume overload. Okay.
Okay. Mhm.
Yeah. Anyone?
Autopsy is
Autopsies.
performed.
Sorry. Mm-hmm.
Histological examination of myocardial tissue reveals thick myocardial fiber with the large hyperchromatic nuclei as well as mild interstitial fibrosis. Which of the following is most likely diagnosis?
So we have thick myocardial fibers, hyperchromatic nuclei, and mild interstitial fibrosis on histopathology. Okay. Now, yeah. So from the start.
Yeah, 54-year-old man come to emergency department due to severe shortness of breath and palpitation. During initial assessment, pulse oximetry showed 83%. Diffuse bilateral crackles are heard on lung auscultation. Chest X-rays consistent with pulmonary edema. ECG
Mhm.
show atrial fibrillation with rapid ventricular response. The patient dies despite appropriate medical care. Autopsy is performed and gross examination of the heart is shown below.
So what do you see on the gross examination of the heart?
It's hypertrophy,
Yeah, and uh, can you say which type of hypertrophy it can be?
Concentric.
um, concentric because the cavity is narrowed like the lumen is narrow.
Yeah, and
Thick wall. The walls are
thick
thick and the cavity is narrow.
thick wall. Yeah, that thick
And the
wall
cavity,
and
the
the
cavity is
cavity is
narrow,
narrowed.
narrowed.
Okay. Yeah, so histological examination of the myocardial tissue reveals thick myocardial fibers with large hyperchromatic nuclei. So they have given you histological examination with thick myocardial fibers, right?
Yes,
And also we have interstitial fibrosis.
fibrosis.
So you have diagnosed it as the
Hypertrophic
eccentric,
cardiomyopathy.
hypertrophic cardiomyopathy is in eccentric, concentric hypertrophy, right?
Yes,
Now, which of the following is most likely diagnosis? So,
C.
what do you think about hypertensive?
Hypertensive is also concentric hypertrophy with two.
Yeah, and so now we have to exclude, is it hypertensive or is it hypertrophic cardiomyopathy, right?
Okay.
Yes.
So how can you differentiate between these two?
On the basis of history, age.
Yeah, and they also have no, the history is not that much clear because they haven't mentioned the hypertension, right?
Yes. On the histopathology, this autopsy
Yeah,
finding
so
may be
on the
different
histopathology, yeah, you can
I
differentiate
think
it. Or
interstitial fibrosis is only seen in hypertrophic. I'm not sure.
because this is reveal a tissue myocardial tissue reveals thick myocardial fibers with the large. So this is thick myocardial fibers and another then hyperchromatic nuclei.
I think
I'm not sure. Maybe
one of you have told me yesterday that in hypertrophic cardiomyopathy, the uh, the hypertrophy type is different than hypertensive, which was banana shape, right?
Yes, sir.
So I can summarize the finding is in hypertensive hypertrophy, you will have symmetrical concentric hypertrophy. Okay, the hypertrophy will be symmetrical.
symmetrical.
Okay, while in the hypertrophic cardiomyopathy, it will be asymmetrical, okay? And the septum size will increase more than the valve, okay? So first thing is the hypertrophy will be asymmetrical in hypertrophic cardiomyopathy, okay? While symmetrical in hypertensive heart disease. All right.
Yes.
The second thing is the shape, which is banana shape, right?
So banana is in hypertrophic cardiomyopathy.
Yeah, banana is in hypertrophic, okay? So the concentric hypertrophy is symmetrical, all right? And while the hypertrophic cardiomyopathy, the septum size will increase more, okay? All right?
Okay. Okay.
The septal size will increase more, okay?
So I also think that in
Mhm.
hypertensive, I think the age, like the patient age in the vignette.
Yeah, this is also
Yeah,
very important.
I
Yeah.
was thinking because this person is 50, 54, so most it goes towards the like the
Mhm.
hypertrophic cardiomyopathy is more in young adults
Yeah, so
and
hypertrophic
hypertension can be in
cardiomyopathy
older
is,
ages.
yeah, hypertrophic cardiomyopathy is before or in their 40s, okay? So hypertrophic cardiomyopathy will be in their 40s, okay?
Okay.
And concentric hypertrophy is in older people, okay?
Okay.
So is it clear now?
Yes, sir. Thank you. So otherwise, this histopathological findings are the same.
Yeah, so the we also have like the myocardial fibers are enlarged, right? We also have interstitial fibrosis in both the conditions, okay?
Okay.
What about cardiac amyloidosis?
There is amyloid deposition, this protein deposition, collagen kind.
Yeah, so you will have amyloid
Staining
deposition, right? Amyloid. So they will mention in histopathology, they will mention is,
apple green birefringent, something like that.
and
Stick.
they will tell you about the amyloid, right?
Okay.
And we don't have such thing on our histopathology, right?
Yes.
And also, it will be restrictive, no, sir?
Yeah, great. So cardiac amyloidosis is of a restrictive type, okay?
Yes.
So my pen is not charged, so we will do some discussion like that, okay? All right. What else we have?
Mitral stenosis and pulmonary arterial hypertension.
So mitral stenosis, we have discussed it previous question as well, right? Mitral stenosis does not lead to eccentric hypertrophy, okay?
Yes.
And what about pulmonary artery hypertension?
There will be right ventricle
Yeah,
hypertension.
easy, right? So pulmonary artery is on right side, right?
So,
So can you summarize the options?
Yeah, in option A, there was like a cardiac amyloidosis. If in case of cardiac amyloidosis, so there will be a clue about like restrictive cardiomyopathy or maybe the histopathology. They give the
Yeah.
staining, the upper birefringent staining clue could be there. And in case of hypertensive heart disease, so there will be a symmetrical hypertrophy as
Mhm.
compared to the hypertensive cardiac myopathy. There is in hypertensive cardiac myopathy, like in hypertrophic cardiomyopathy, this hypertrophy will be asymmetrical and the septum size will be larger or bigger as compared to with the hypertrophy in the hypertension. And
Yeah, and
there
the
can be
septum size, yeah, the septum size increase more than the walls of the ventricle, okay? And
yes,
here the
and
wall of the ventricles are pretty enlarged.
thicker. Yeah, and there
Mm.
could be a banana shape, the shape
Yeah,
of the septum.
yeah. And Mitral stenosis does not lead to concentric
Venous
hypertrophy.
hypertrophy.
And the last one is right
Pulmonary arterial hypertension.
right ventricular hypertrophy.
Hypertrophy.
Clear,
Yes, sir.
everyone?
Thank you.
Yeah.
So they have given you is uniformly thickened left ventricular wall, right?
Okay.
Yeah, anyone?
Compared to an unaffected child, which of the following changes in oxygen saturation would be expected in this patient? A 4-year-old boy is brought to the office for routine evaluation of a heart murmur. The
Mm-hmm.
patient has no fatigue, shortness of breath, or exercise intolerance. He has no other medical condition and has had no surgeries. Vital
Mm-hmm.
signs are within normal limits. On examination, the patient has no sinuses or clubbing of the fingers. There is harsh 3 by 6 holosystolic murmur, best heard at the left lower sternal border. There are no
Mm-hmm.
rumps or gallops. Pulses are 2 plus in the upper and lower extremities. Compared to an unaffected child, which of the following changes in oxygen saturation would be expected in this patient?
So what do you think we have? 4-year-old boy,
Yes.
right?
Yes, sir.
Mhm.
For evaluated for a murmur, right?
Yes, sir.
He has no fatigue, no shortness of breath, and no exercise intolerance. Okay, and no history, no medical and surgical history. Okay, vital signs are within normal limit, and he does not have any cyanosis, right? But we have a harsh holosystolic murmur, best heard at left lower sternal border. So, what's the area is called? Left lower sternal area is
Tricuspid area.
tricuspid area, and we also have VSD
VSD.
over there, right?
Yes,
Right.
sir.
No cyanosis means
Left to right shunt.
left to right shunt. Okay. Pulses are 2 plus in the upper and lower extremities, so pulses are the same, right? Compared to unaffected child, which of the following changes in the oxygen saturation? Now they are talking about the mixing of the blood, right? They are talking about
Mixing of the
oxygen
blood.
saturation, right? So uh, they are concerned about whether in right atrium, left atrium, where the oxygen get mixed with the deoxygenated blood get mixed with the oxygenated blood, right? So when you diagnosed a case, so I think the rest of the question is very easy, right?
Yes, sir.
So yeah, so what do you think? Now we have a shunt from left to right is in VST. Okay.
Yes, sir.
So now tell me, what's your answer?
D.
D. So how is this? So right atrium, you are saying right atrium is normal, right?
Yeah, yes, sir.
So the oxygen saturation does not mix up in right atrium. Clear?
Yes, sir.
In right ventricle, the oxygen saturation is increased, right?
Yes, sir.
Why it is increasing? Because the oxygenated blood is coming from left ventricle to right ventricle. Okay,
Yes, sir.
and why the rest are normal?
I mean, because the patient is asymptomatic and there's no
Yeah,
problem.
so that's also a clue. Great point. Yeah, but if you see the aorta is getting blood to the body, right? Yeah. And
Yes.
when we have, yeah, so this blood is going to lungs, right? So
Yes.
again, it is getting saturated, okay? So we don't have any further mix up, okay? So this will be normal, and this also, right?
Oh, yes, sir. This made this is better understanding than that one. Yes, sir. Got it.
Yeah, and you can say it from no cyanosis as well, okay?
Why this murmur is harsh?
Yeah, so when we have a small VSD, right? So the blood is passing through the septum in a high pressure, okay?
Okay.
So in cases of small VSD, the murmur will be harsh, okay? And when the VSD is large, so the murmur is not that much harsh, okay?
Okay.
So you will have a hollow systolic murmur only, okay?
Okay.
So I think the question is easy. You just have to diagnose the condition, okay? And now you can easily diagnose it is from the location and type of murmur, okay? So I have told you the systolic murmurs, right? Right, guys?
Yeah.
And we have discussed the systolic murmur is like mitral regurg, aortic stenosis, right? VSD, and hypertrophic cardiomyopathy. And the location tells us that it's VSD, left lower sternal border. Tricuspid location, remember the mnemonic is TV, okay? All right,
Yes,
clear?
sir. Yes, sir.
Okay. You can see it in the picture as well, okay? So only the blood is mixing in right ventricle over here, right? Clear?
Yes, sir.
Yeah, anyone?
I can go.
Mm-hmm.
Which of the following drug effects is most likely to produce this phenomenon? Atherosclerotic lesions of the coronary arteries can limit blood flow to the myocardial regions supplied by the affected vessels. In some patients, certain medications can cause a redistribution of blood flow away from the ischemic areas, exacerbating existing myocardial ischemia. Which of the following drug effects is most likely to produce this phenomenon?
So what do you think, which phenomena are they talking about? So can you go through the stem and tell us the high yield points?
I think they're talking about drugs that would take the blood away from the ischemic areas, and so that
Mhm.
would worsen the myocardial ischemia.
Yeah.
Um,
So we call it as coronary steal syndrome, right?
right.
So let's go to the stem again. We have an atherosclerotic lesion, right, of the coronary arteries can limit blood flow to myocardial region supplied by affected vessels. In in some patients, certain medication can cause redistribution of blood flow away from the ischemic areas, exacerbating existing myocardial ischemia. Which of the following drug effect is most likely to produce this phenomena? So, what do you think normally happens when we have atherosclerosis? Like if this is a vessel, right, and if it's blocked,
Blood flow
right?
decreases.
If it's blocked, right? So vessel down there does not receiving
Receive enough
blood,
blood
right?
flow. Yes.
And and this vessel try to dilate, right? This is normal phenomenon, right? So till maximum dilation, we have the phenomena of ischemia, right? Now come over to the medication. So what happens when we give medications? Hello?
Dilation of the arteries.
So give me some 2-3 minutes so the pen start working, okay? So it's on charge, all right?
Yes,
So I'm
sir.
drying by hand and it's not working properly, okay? All right. So are you guys there? Hello?
Yes, sir.
Okay.
Yes, sir.
So so the first line we are discussing it as an atherosclerotic lesion like this one, right? The coronary arteries can limit blood flow to the myocardial lesion supplied by the affected vessels. So down here, the blood supply are decreased, right? In some patients, certain medications can cause redistribution of blood away from the ischemic area, exacerbating existing myocardial ischemia. So, what do you think? Which type of drug are they talking about?
Vasodilator.
Yeah.
Vasodilators. Yeah.
And what are the examples we use?
Nifedipine, hydralazine.
So over here for this test, we use adenosine, okay, and dipyridamole, okay, dipyridamole, okay. So what these drug do is they are trying to vasodilate these vessels, okay. So they are trying to vasodilate these vessels, all right. But when we have like 70% occlusion, right? So these vessels are maximally dilated, okay? So they are already dilated to its maximum capacity, okay? So by giving drugs that vasodilators, these arteries cannot dilate more, okay? All right? But the normal arteries that are not ischemic or where we don't have atherosclerotic lesions, so they can dilate, right?
Yeah.
Right, guys? So what happens is when we give drugs to some patient and they respond with the vasodilation of the other arteries other than the arteries that is being blocked, what happens is the blood shifts to that part, okay, the vasodilated part, okay, and the blood that is received by the already ischemic vessels is shifted to dilated vessels, okay, all right,
Yes, to the non-ischemic ones, right?
to the non-ischemic ones.
Yeah.
And the whole phenomenon we call it is coronary steal syndrome, okay, all right, all right.
Yeah. Yes.
Yes,
So
sir.
now come over to the question, which of the following drug effect is most likely to produce this phenomena? So what do you think? How is the phenomena working?
By
What
dilation.
what does the
Which one?
what does the drug do?
Dilation.
Coronary
Coronary
arteries
arterial dilation.
artery dilation. So again, if we have two arteries, one is sclerosed, okay, and is maximum dilated, okay. So when we give vasodilators, so the effect of vasodilator does not work here, rather it dilates the normal vessels, okay, and the blood flow shifts to these normal arteries, okay. So we have an option is coronary arteriolo dilation, okay, all right. Yeah, you can read this is from here to here. So adenosine and dipyridamole do what? Using are used during myocardial perfusion imaging to stimulate exercise-induced coronary arteriolodilation, which leads to what? The drugs will result in significant increase in flow to non-ischemic myocardium and no change in blood flow to ischemic myocardium. Okay, all right, and all the phenomena we discuss is called as coronary steal. All right. Yeah, so it's pharma. We will skip this one. Yeah, anyone?
Which of the following is the most likely cause of the observed finding in this patient? A
Mhm.
34-year-old woman is being evaluated for fatigue and progressive exertional dyspnea. She goes mountain biking with friends a few times a month and recently noticed that she has to stop and rest more frequently when traveling uphill. The patient
Mm-hmm.
has no significant medical history and takes no medications. She occasionally drinks alcohol but does not use tobacco or illicit drugs. Her father died of a myocardial infarction at age 72. Lung auscultation is normal, and echocardiogram shows an enlarged coronary sinus. Which of
Mm-hmm.
the following is the most likely cause of the observed finding in this patient?
So, what are the findings we have? The important thing we have is in enlarged
Echo. Yeah, enlarged coronary sinus.
coronary sinus. So, we have a 34-year-old woman being evaluated for fatigue and progressive exertional dyspnea. So, fatigue, exertional dyspnea. She goes on mountain biking with friends and recently noticed that he has to stop and rest more. Okay. The patient has no significant medical history and takes no medication. She occasionally drinks alcohol, does not use tobacco and any illicit drugs. Her father died of a myocardial infarction at age of 72. Lung auscultations are normal. Which of the following is most likely cause of the observed finding in this patient? So the only finding we have is fatigue, dyspnea, and dilated coronary sinus, right?
Yeah.
Right. So where do the sinuses drain?
Right atrium?
Right atrium, right?
Yes, sir.
And can the increase in right atrial pressure leads to coronary sinus enlargement?
Yeah.
So what do you think we have? Look over to the options.
Pulmonary hypertension.
Yeah, so can aortic dissection lead to increased right atrial pressures?
No, sir.
No. No.
No.
Pulmonary
And
hypertension.
how does the pulmonary hypertension leads to increased right atrial pressure?
Because
Congestion
Because
with blood flow.
yeah, because if we
Increased
have
resistance.
if we have like increased afterload or increased resistance over here in the pulmonary artery, right? So the pressure will backflow is right ventricular pressure increase, right? And it can affect right atrial pressure. Okay, all right.
Okay, sir.
And if you look into the other options like pericardial effusion, so pericardial effusion will compress the coronary sinus, right? Pericardial effusion can compress the, but it does not dilate the coronary sinus. Okay, so the easiest thing to remember about the coronary sinus is where does it drains, right? Right, and anything that increases the right heart pressures would lead to enlargement of coronary sinus, right?
yes,
Clear?
sir.
Yes, sir.
Yes. Yeah.
Like option A, so aortic dissection. So will it affect the right heart or the left heart? Aortic dissection.
Left
It will
heart.
affect the
Left heart.
left
Left.
ventricular pressures, right?
Yeah.
So they just asking about, or they are more concerned about the right heart pressures. Okay, all right.
Yes, sir.
Okay, so let's see which option was it.
E.
E.
E, right?
Yeah.
So yeah, they are saying elevated right sided heart pressures due to pulmonary hypertension. Okay. Yeah. You guys are tired.
If this patient has survived, he would have been at a greater risk for which of the following events? A
Mm-hmm.
2-month-old boy is found unresponsive in his crib. He had previously been well and had a normal physical examination at his 2 month visit approximately 1 week earlier. An
Mm-hmm.
autopsy is performed to determine the cause of death. The pathologists conclude that the infant likely died of sudden infant death syndrome. The
Mm-hmm.
autopsy also shows an incidental finding of bicuspid aortic wall. If this
Mm-hmm.
patient had survived, he would have been at greater risk of which of the following events?
So we have a 2-month-old boy, right? A 2-month-old boy found unresponsive. He had previously has been well and had normal physical examination at 2 months visit approximately 1 week earlier, right? An autopsy performed for the cause of his death. The pathologist concluded the infant likely died of sudden infant death syndrome. The autopsy also shows incidental finding of bicuspid valve, right? So normally the aortic valve is
Tricuspid.
right. So the aortic valve is having three cusps, right?
Yes, sir.
And we have some congenital abnormality found in the baby, which was bicuspid valve, right? If the patient had survived, he would have been at greater risk of which of the following event. So they are talking about if we have a bicuspid valve and the patient survives, so what will happen in the coming years of his life?
Aortic
Aortic
stenosis.
stenosis in his 50s.
Yeah, so the risk of aortic dissection is increased, right? The risk of aortic stenosis is increased, okay? All right. The risk of endocarditis is also increased, okay? All right. Same again, the stenosis, aortic stenosis risk is increased, okay? And does not have anything, and the bicuspid aortic valve does not have anything with arrhythmias. But the thing is, we are seeing aortic stenosis in the 50s, okay? You can see the patient can develop aortic dissection, but not in his 30s, okay? And the risk is increased, but not that much, okay? So when we compare a bicuspid valve patient with a normal patient, a normal person, so the aortic dissection risk is greater in bicuspid aortic valve patient, okay? So why do we have aortic stenosis in his 50s while if we compare it, while in comparison to normal people, we have aortic stenosis due to aging of like 70s, right?
Yes, sir.
And in such patient of bicuspid aortic valve, we have aortic stenosis in 50s. Why?
Because of this abnormal valve, these two cusps.
Yeah, so we have two cusps. We have a chronic turbulent flow over there, right? So the abnormality we have is bicuspid valve, and the flow over there is turbulent for a long time, okay? And that's lead to calcification of aortic valve, okay?
So, sir, what will be the age for aortic dissection?
So the aortic dissection, they we do not have the exact age from the studies, okay? But
Okay.
we only know the risk is increased, okay?
Okay.
We can
Okay.
have aortic dissection because of the turbulent flow, okay?
Okay.
All
So
right.
which option will be which option will be correct? Aortic dissection or aortic stenosis?
The,
Because
the
both are high risk.
the risk is high, but if you look it to the age, so the aortic dissection does not happen in 30s when we have bicuspid aortic valve, okay? So it can
Okay.
happen in the 60s, 70s, okay?
Okay, got it. Got it. Okay.
But the
Okay.
stenosis, almost more than 50 to 60% of the patient they develop stenosis in his 50s, okay? And the reason for
Okay.
it is turbulent flow leading to calcification of the
Classification.
valves, okay?
Okay. Thank you so much, sir.
All right,
Thank you.
no problem. So this is normal aortic valve with three cusps, right? And now we have conjoined two cusps, so we only have two cusps remains, okay? All right, clear?
Yes, sir.
Yeah, anyone?
I can read. Which of the
Mhm.
following processes is most likely contributing to this patient's elevated hematocrit? A 6-month-old girl brought to the office for her first visit after being adopted from another country a week
Mhm.
ago. The parents note that she often seems to breathe hard and fast,
Mhm.
particularly after feeding or crying. Her lips also sometimes turn blue. On
Mhm.
examination, height and weight are the 15th and 2nd percentiles, respectively. The patient has a 4 by 6 harsh systolic crescendo decrescendo murmur, best heard at the left upper tunnel border. The results are complete blood count are as follows: hematocrit 52%,
Mhm.
platelets 240,000, leukocytes 11,000. Which of the
Mhm.
following processes is most likely contributing to this patient's elevated hematocrit?
So we have 6-month-old baby, right? And he has been adopted from another country, so they didn't know what's his congenital abnormality, okay? And she seemed to breathe fast and hard, particularly after feeding or crying. She turns blue, right? So we have cyanosis after
So, right to left shunt.
crying, right? And what else we have?
We have increased hematocrit.
Yeah, so increased hematocrit, cyanosis, and what about the murmur? Hard systolic, crescendo,
Stenosis.
decrescendo murmur, best heard at the left upper sternal border. So what do you think the murmur is?
Tricuspid.
So
Pulmonary
Three.
stenosis.
first, what's the
Aortic
location?
stenosis.
What's the location?
Upper left sternum is
Left upper
pulmonary.
tunnel border.
Left upper
Pulmonary.
has pulmonary area.
Pulmonary area, right? Right?
Yes.
Yes.
So now you can exclude the VSD and the aortic and other murmurs, right? Clear?
Mhm. Yeah.
And we have diagnosed is the shunt is right to left shunt, right?
Pulmonic valve
So
stenosis.
so we have pulmonic stenosis. How is this stenosis? Because we have crescendo decrescendo, right?
Mhm.
Diastole.
Yes, sir.
Because we also call it crescendo decrescendo is also called a systolic ejection murmur, okay? The crescendo means first it increased till some pressures, and then when the valve opens it decreases, right? Right. So I'm not going to
Yes,
confuse
sir.
you.
Yeah, it
So
Yeah,
increases
reduce
this
blood flow.
so
blood
I'm
pattern.
not I'm not confusing you. So the first thing is we have a cyanotic baby, and the cyanosis occur after crying. So the thing is we have a right to left shunt, okay? So by increasing stress or pressure, the right sided blood now can mix up with the left, okay? It's not continuous, okay? So if it was continuous, so the cyanosis will be all the time, right? The second thing we have is murmur aid, left upper sternal border aid, pulmonic area. Now we also have is in systolic crescendo decrescendo, which is for pulmonic stenosis, right? So two condition we have. One is pulmonic stenosis, and the second thing is right to left shunt, right? So what do you think they are leading us?
The
Which
tetralogy of
condition?
Fallot?
Yeah. So pulmonic stenosis, right? And VSD, right?
Yes, sir.
So they have given you the hint of shunt and pulmonic stenosis, okay? All right.
Yes, sir.
And now they are asking about why the hematocrit is high. So when do we have increased hematocrit in general sense?
When there's
Hypoxia.
increased erythropoietin.
When
Hypoxemia.
we have decreased oxygen or increased erythropoietin production, right? Right?
Yes, sir.
So now tell me, you have your diagnosis of tetralogy of Fallot, right? So we have TOF. This is, we have overriding aorta, we have VSD, right? We have pulmonic stenosis, right? And ventricular hypertrophy. All four can be in tetralogy of Fallot, okay? So what do you think the decrease in oxygen content, why do the O2 oxygen content, or we can say elevated hematocrit, can occur? Because we have,
Decreased blood flow to the kidneys, and that would be sensed by the cells. So they would release more erythropoietin.
yeah, so first thing is the flow is decreased down there, right? Due to pulmonic stenosis, right? Clear? The second thing is we have right to left shunt, okay? Clear?
Yes, sir.
So now when we have right to left shunt, so we have decreased O2 content in aorta, right? And this blood is going to the body is decreased O2 contents, right? And when this is sensed by kidneys, it can lead to increased erythropoietin. Okay, clear?
Yes, sir.
So what's the main reason behind it is the normal flow through pulmonic system is decreased. Okay, all right.
Yes.
Any question? So anyone who wanna summarize it just in simple terms, make it very easy. Okay.
It's because when there is reduced blood flow overall, and so
Mm-hmm.
obviously every system is receiving reduced blood flow. When this
Mm-hmm.
would be sensed by the kidney,
Mm-hmm.
the interstitial cells of the peritubular capillaries will release erythropoietin, which
Mm-hmm.
would cause increased production of the red blood cells.
Yeah.
So that is the main mechanism here.
Yeah. So we have cyanosis, right? It is sensed by cyanosis means decrease O2 content, right? The reason for cyanosis is we have diagnosed the condition is TOF, okay? And all the blood leading to kidney sense decrease O2, right? Leading to increased production of erythropoietin, which is causing increased formation is hematocrit, right? Clear?
Yes, doctor.
And what happens in tetralogy of Fallot? We have pulmonic stenosis, right? So the blood is not going through pulmonary artery, the deoxygenated blood, rather it goes to aorta, leading to decreased O2 content, okay?
Got
Clear?
it. Yeah.
So actually the pathophysiology somehow confusing, okay? So we will try to make it easy, okay? Yeah, anyone?
Okay, I can go. Which of the following temporary measures would be most likely to improve this patient condition? A full-term newborn is evaluated in the delivery room due to mild tachypnea and cyanosis immediately after birth. Fetal
Mm-hmm.
ultrasonography performed during pregnancy revealed transposition of the great arteries. Heart rate and blood pressure are normal. Oxygen saturation is 72%. Cyanosis is apparent in the hands, feet, lips, and tongue. The
Mm-hmm.
peripheral pulses are strong.
Mm-hmm.
Bedside echocardiography confirms the prenatal diagnosis. There is also small patent foramen ovale and small patent ductus arteriosus. Definitive surgical correction of the main congenital abnormality is planned. Pending definitive repair, which of the following temporary measures would be most likely to improve this patient condition?
So in summary, we have a condition is in tetralogy, sorry,
Transposition.
transposition of great vessels,
Yeah.
right?
Yeah.
And you know, in transposition of great vessels, aorta is on the right side and pulmonary artery is in on the left side, right?
Yeah.
And for the normal survival, we need shunts, right?
Sure. Yeah.
If we don't have a shunt, so this this is making a separate circuit and this is making a separate circuit, okay? So the blood from the body does not get into the lungs, and the blood from the lungs does not gets to body, right?
Yeah.
So we need shunt for it, okay? So the shunt can be like pattern for a Manovelli over here, ASD, right?
Yes.
Or PDA like here. So it can be a PDA or VSD, okay? So we need at least one shunt, right?
Mm. Yeah.
For the survival, okay?
Okay.
Now, what does the question is asking? Definite surgical correction of the main congenital abnormality is planned. So the surgery is planned pending definitive repair. Which of the following temporary measures would most likely to improve the patient condition? So I have told you we need shunts for
Mm.
normal survival, right?
Yes.
So making the shunts, like we have small shunts, right?
Mm.
So either making the shunts bigger or maintaining the patency of PDA, right?
Yes.
So these two conditions will improve the patient condition, right?
Mm. Yes.
So now look over to the options and tell me.
D.
D.
Yeah. So
Mm.
either D or giving prostaglandins, right?
Yes.
So these two are necessary for the
Mm.
survival of the
Yes.
patient with transposition of great vessels, right?
Yes.
So clear?
Yeah.
All right. So enlargement of patent foramen ovale. All right. Anyone?
Which of the following oxygen saturation percentages are most likely present during the cyanotic episode? An old bo- 8-hour-old boy is being assessed for a murmur in the newborn nursery. The patient was born at 37 weeks via cesarean delivery. EPGAR scores were 7 and 8 at 1 and 5 minutes, respectively. He was noted to have a harsh systolic ejection murmur or 4 by 6 intensity during the initial newborn examination. Brachial and femoral pulses are 2 plus with no delay. While the patient is breastfeeding for the first time, his face, lips, hands, and feet become cyanotic. The
Mm-hmm.
murmur cannot be heard during the cyanotic episode. Which of the following oxygen saturation percentages are most likely present during the cyanotic episode?
So again, let's diagnose the condition, okay? We have an 8-year-old boy with a murmur, right? Born 8:37 week via cesarean. APGAR score is 7 and 8 respectively. We have a harsh systolic ejection murmur, right? Brachial and femoral pulses are 2 with no delay. While the patient is breastfeeding for the first time, so again we have cyanosis during feed, right? The murmur cannot be heard during cyanotic episode. So what do you think we have?
VSD.
So yeah, right to left shunt, VSD, right? Yeah. And
Yes.
what about the systolic ejection murmur, which is a hint given is the murmur decreases with the cyanotic episode. If it's VSD, so the murmur should increase because the flow is increasing, right? During the cyanotic spell, right? What do you think, guys?
TOF.
Yeah, so it is talking about again the same thing, TOF. Previous question, they have given you the same murmur, right? But they have told you the location, right? Pulmonic area, right? Right, guys? Now they are saying that the murmur is decreased with the cyanotic episode. So what happens to the murmur during this phase? So if this is heard, right, this is VST, this is overriding aorta, this is pulmonic stenosis, right? So they are saying that when we have blood flow from right to left, when the blood flow from right to left increased, or we can say the cyanotic spell, right? The murmur decreased. And which type of murmur we have? Harsh systolic murmur. So why the murmur is decreased? Why this murmur is decreased?
Because there is increased venous return.
Because the flow is to the different side. Here we have pulmonic stenosis, right? Right?
Yes, sir.
Yeah.
So let me make it more clear. So when do we squat? When a patient squat, right? Increasing the afterload, right?
Yes, sir.
The cyanosis decrease, right?
Yes, sir.
Because this flow is going that way, right?
Yes.
And the opposite is happening, and they are saying the murmur cannot be heard during the cyanotic episode. Means when the baby is crying or feeding, the blood is going this way, right?
Yeah.
So the blood does not go through, or the blood volume that is going through the stenotic wall is decreased. That's why the murmur is decreased. Okay, all right.
So,
Yeah.
sir, you
Mm-hmm.
mean during cyanosis,
Mm-hmm.
or when the baby is feeding,
Mm-hmm.
at that moment the blood is flowing through the VSD and not from the pulmonary artery?
Yeah. So when do we hear the murmur? When the blood flow is like this. Okay, but
Okay.
when the baby is feeding or crying, the blood flow is like this. Okay, not all the blood flow, but the blood flow is decreased from this path. Okay,
Yes, sir. Okay.
that's
Okay. So,
why that's
all right.
why the stenosis is decreased. Okay, all right.
Yes, sir.
So just remember, for making thing easy, just remember, if they have given you a hard systolic murmur at the left upper sternal border, so it's clear it's a pulmonic area. Okay, all right. But if they have given you a murmur which is not VSD murmur, okay, all right. If they have given you a murmur along with the cyanotic spells, all right, so it will be tetralogy of Fallot. Okay, clear?
Yes, sir.
Or we can say which type of uh, which type of shunt we have in ASD VSD.
Left to right.
Left to right.
Left to right. Okay, clear? So
Yes.
normally we have left to right VSD shunt, right? And in tetralogy of Fallot, the shunt is opposite,
Right
right?
to left. Yeah.
So this is Eisenmenger syndrome, sir? Is that what they're talking about?
But Eisenmenger is specifically when we have increased pulmonary resistance, okay, and
Okay.
the shunts got reversed, okay. But here we have pulmonic stenosis congenitally, okay, all right.
Okay. Okay.
So
So
the
that's not
thing,
the.
yeah, so the thing is the same, that we have increased resistance to the flow and the change of the shunt from left to right. So you're right, but
Okay.
here the problem is congenitally present like that. Okay, and
Okay.
Eisenmenger, first we have left to right shunt and then it becomes right to left. Okay,
Okay. Yeah. So here also we are having a right to left, right, sir? In this case.
no, he only have left to right shunt because of pulmonic stenosis.
Okay.
But the point I am making is that if you see in a stem a pulmonic murmur, okay, along with
Okay.
the cyanotic spells, so
Yeah.
it will be leading us to tetralogy of Fallot. Okay,
Okay.
But if you are unable to confirm the murmur of the pulmonic stenosis, so look over to the VHD, and if the VHD is leading to cyanosis, right,
Yeah.
it means we have right to left shunt, right? And normally in VHD, the shunt is left to right, okay?
Yeah.
So this is one point. So look for the VHD. If the cyanosis is there, means we have right to left shunt, okay? And the other thing, they will have given you a murmur, okay?
Okay.
So these clues are leading us to tetralogy of Fallow, okay?
Okay. Got it.
Now,
Thank you.
no problem. Now come over to the question, what are they asking about? So we have diagnosed our cases in tetralogy of Fallow, okay? So which of the following oxygen saturation? So now they are talking about the physiology. Oxygen saturation percentage are most likely present during cyanotic episodes. So first thing is you should have you should have to know what's the normal oxygen saturation, and then you will be able to find out the abnormality, right? Right?
Yes.
Yes.
So anyone knows what's the oxygen saturation?
98.
That's 5 to 100.
So 98 over here, 98 over here, right? And it's coming from the lungs, so 98 over here, right? And going to aorta, 98 over here. Clear?
Yeah.
So it's easy. On this side, it's 98, okay? And from vena cava, it's coming is in 75%, 75%, and pulmonary artery also 75, goes to lung, gets oxygenated, and come back is in 98% saturated, okay? Clear?
Yeah.
So this is the normal oxygen saturation, okay? Now we have our case of tetralogy of Fallow, okay? And we have shunt like this. Clear?
Yeah.
Yes.
So
That's
normal is
48.
75 here, 75 here, 98 here. So what do you think the tetralogy of Fallow doing to the oxygen saturation in right ventricle?
Decreases it.
Normally it's 98, right? So it should be decreasing, okay? Clear?
Yeah.
Yes.
So it is not affecting this one, does not affecting this one, and does not affect the right atrium. Why? Because the right atrium is receiving blood from the lungs, right?
Yes.
Yeah.
Yeah.
And the left atrium is receiving it from the body, right?
Mm.
As in venous circulation. So the only place where the mixing of the blood occur is from right ventricle to left ventricle. Sorry, from right ventricle to left ventricle. Okay,
Yeah.
So the left decreases saturation of oxygen.
clear?
Yeah.
So now tell me the answer.
A.
Is it?
So right atrium does not change, right? Then right ventricle again the same, pulmonary artery again the same, right? The only place where the blood is mixing is in left ventricle, right?
Yes.
Clear?
Yes, sir.
Was it easy?
Yeah.
No,
After
Yeah.
all
it
the
was very
discussion,
fun.
yes.
Yeah, it was not easy. Yeah, so we have a graph over here now, okay? 75 to 80, okay? Why it's becoming 80? Students got confused. Getting is why the deoxygenated blood is increasing the percentage, but actually it's decreased from 98, okay? Okay?
Yeah.
Okay, sir.
All right. So let's see if you guys can hear the sound.
It seemed like murmur.
Feel like me.
So yeah, anyone want to read?
Oh, which of the following is the most likely diagnosis? This item has associated. Oh, a
Mm-hmm.
12-month-old boy is brought to the pediatrician by his parents for an upper respiratory infection. Temperature is 38.3 Celsius. Blood pressure is 92 over 45. Pulse is 110 per minute and respirations are 25 per minute. Physical examination shows erythema and swelling of the nasal mucosa and nasal discharge.
Mm-hmm.
Cardiac auscultation findings at the left sternal border are given below. Pulses
Mm-hmm.
are equal on all four extremities. The remainder of the examination is unremarkable. Which of the following is the most likely diagnosis?
So the first thing is 12-month-old boy with the fever, increased heart rate, respiratory rate, erythema. So he had some infection, right? Now on cardiac examination, we have left sternal border, right? A murmur on a left sternal border, okay? Pulses are equal in all four extremities. The remainder of the examination is unremarkable. Which of the following is most likely diagnosis? So you heard the murmur, and
Yeah.
the murmur is in left sternal border.
So, sir, I have a question.
Mm-hmm.
Um, like, will be given clues to identify these murmurs, or do we really need to know how they sound like for the exam? Because they can give us sounds and just ask us what the murmur was. Like, do we really need to be able to identify all of them through just hearing them?
Yeah, but I guess you need to identify the high yield one like PDA, okay, which has classical machinery murmurs, okay, and some others like mitral regurgitation, okay, holosystolic murmur going to the apex. So maybe some murmurs you need to know it from the sound, okay.
Okay, thank you.
So we have murmur which is a
Mach-
machinery murmur, okay. So I can't explain the sound, but yeah, I will play it again. Machinery murmur is in PDA, right? So they have, yeah, so look over to the video and you will, now you will identify it is, okay?
It's continuous.
Yeah, if you look into the graph, so they have given you is in continuous machine like murmur at the interscapular area, Okay, right? From
Yeah.
the start of like S1 from the start of the systole till the end of the diastole, right? This is how the figure is, right?
Yes, right, doctor.
Yeah, just read the figure and I will play it again so you can understand the sound, okay? From S1 to from S1 to S2 is systole, then S2 to S1 is diastole, right? And the murmur is heard from one S1 to another, right? So this is systole, right? This is diastole, right? And the murmur will be heard from here to here, okay? Clear?
Yes, doctor. Mhm.
Now, and we call it as in continuous machine like murmurs which is present during systole as well as in diastole. Now you can hear it again, okay? Yeah.
Yes.
Okay guys, I can't explain it more than this, okay? We don't have any more clues given in this time, okay?
Yes, it's okay. We'll watch and we'll learn these sounds.
All right. Yeah.
This patient is most likely to die from which of the following conditions? A 19-year-old man comes to the office due to difficulty seeing and blurred vision, which have worsened slowly over the past year. He is a
Mhm.
second year college student pursuing a degree in biochemistry. His grades are excellent, but he is concerned about the effect his poor vision has had on his classes this semester. The patient
Mhm.
is also an avid swimmer. He weighs 71 kilos and is 195 centimeters tall. Physical examination shows the findings seen in this exhibit. This patient is most likely to die from which of the following conditions?
So, can you see the exhibit?
Yes, sir.
Yes, sir.
What can you appreciate here?
Pectus
This
excavatum.
is Kavansu.
Yeah, pictus, pictus excavatum, right?
Mhm.
And where do we see pictus excavatum along with
Parfans.
Marfan
Pass.
syndrome.
Marfan.
the long extremities, right?
Mhm.
Arachnodactyly.
Yeah, and what else? Scoliosis,
Kyphosis too.
kyphosis and scoliosis, right?
Yeah.
And pectus excavatum, right?
Can we see pectus carinatum too?
I don't know, sorry. And now come over to the question. Yeah, so can you summarize it?
They will get aortic root dilation. Oh.
So can you summarize the question?
So a
We have
young who's studying has difficulty seeing Marfan syndrome. So he's having Marfan syndrome.
Yeah, so
Uh,
we had blurred vision, yeah,
yeah,
which is worsened over the years.
yeah,
And yeah, so all the sign and symptoms of Marfan syndrome, right?
yeah. He's thin, tall, long extremities.
Mm-hmm.
Um,
So yeah, so what do you think Marfan syndrome,
big disease,
like in cardiac
cardiac,
conditions, which two conditions are
cardiac
most important
dissection,
in which two
uh,
conditions are most important in Marfan syndrome?
Aortic
it's
dissection,
every dissection.
aneurysm,
Yeah,
And
and
so
multiple collapse.
yeah, so we have
Aortic root dilatation.
yeah, so or medial wall of the aorta is affected over here, okay?
is that the cystic medial necrosis they talk about?
Yeah, we call it cystic medial degeneration, okay?
Necrosis, yeah.
And that leads to aortic aneurysm
Dissection. Aneurysm.
and which is leading to aortic dissection, okay?
Yeah,
All right. And the
yeah,
question is asking that this patient is most likely to die from which of the following conditions?
yeah. So aortic disease, right?
Clear?
Yeah. And so
So
this
if
blurred vision is due to what is that condition called, sir? There's a certain name for that.
Sorry?
Um,
Lens
the blurred.
subluxation.
That's subluxation. Right. Okay. So
Yeah.
okay. That's it.
So we have aortic disease. So I will do one more question. Okay.
sir, is the blurred vision from lens dislocation, and is that
Yeah.
the same? Okay.
So again, we have some sounds. Okay. So we'll skip this one. Yeah. So I think you guys should do the rest of the questions and let's discuss some of the sounds. Okay. They are important. So I will do some sounds in 5 to 10 minutes and we'll end up the class. Okay. All right. All right, guys.
Yes.
Okay.
Now you have to tell me, okay? So what are the systolic murmurs?
Mitral regurg,
So
aortic stenosis.
Aortic
along with
stenosis.
mitral regurg, the same is,
Uh, tricuspid
right?
regurg.
So this is mitral and tricuspid are the same, okay? And we have remembered it like this. The second is
Aortic
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 pulmonary
stenosis.
stenosis.
pulmonary
and
stenosis.
pulmonic stenosis, okay? Also VSD, right? And
Hypertrophic
hypertrophic
cardiomyopathy.
cardiomyopathy, okay?
Cardiomyopathy.
So memorize these, okay? And the rest are diastolic, okay? All right.
Okay, so
Now again, so this is in aortic area. This is pulmonic, right? This is tricuspid, and this is mitral. Okay. This is second intercostal space. It's also second. This is fifth, and this is fifth. APTM 2255. Okay.
okay.
All right. So we also have left sternal border over here, right? So aortic stenosis here and aortic regurg here. Okay. All right. Also, at the left sternal border, we have hypertrophic cardiomyopathy murmur. Okay, clear? Clear, guys? Okay, so other thing in the so here we have aortic stenosis. Now, pulmonic area. Here we hear pulmonic flow murmurs, right? So here we have pulmonic flow murmurs as well
Mm,
as
ASD.
ASD and
PDA.
PDA, right? And why the ASD is heard over here?
With the
Because
blood flow.
the blood flow from left to right is increased here, causing increase in the pulmonic flow, right? Clear?
Hmm. Yes, sir.
Now the third one, tricuspid, okay? So here we heard is the tricuspid murmurs as well as VST, right? TV, okay? Clear, guys?
Yes.
And mitral regurg will be heard as it in apex, okay? Mitral stenosis and mitral regurg, okay? Done? Yeah, now let's discuss ASD, VSD, and PDA, okay? So ASD is heard at which area?
Pulmonic P2.
Pulmonic area, right? And all these three are
Left to
left
right
to
show.
left to right shunts, right?
Mm-hmm.
Now tell me, how does the ASD sound is? We call it pulmonic flow murmur, and I have explained why it's called pulmonic flow murmur, right? It's also pulmonic flow murmur is also an systolic murmur, okay? Okay, and we will have wide fixed split of S2. You know this, right? Why do we have split? If this is S1, this is S2, this is systole. So in S2, we have closure of aortic and
Pulmonary valve.
pulmonic
Pulmonary.
valves, okay? In ASD, I have told you the flow over the pulmonic valve increase, right? Right?
Yes.
Which is leading to the closure of the pulmonic valve late, okay? Okay, guys. That's why we have wide fixed split of S2, okay? Clear?
Okay.
Yeah.
Yeah.
Where do we hear the VSD? It
The
right,
tricuspid
it tricuspid
area.
area, right? Right. Normally, the VSD is from
Left to right shunt.
left to right, and due to when we have cyanosis, it can be reversed.
Reversed.
So I will just simple write it in reverse, okay? Due to ventricular hypertrophy or increase pulmonic resistance, okay? So the constant increased flow through the pulmonic valve can lead to increase in pulmonic resistance, okay? So when we have constant increased flow through pulmonic valve, so this valve is damaged, okay? All right. Yeah, so what type of sound we hear in the VSD? We have discussed it so many times in questions. Hollow,
Hollow systolic murmur.
Systolic.
Mhm.
systolic, murmur, right? And the same hollow systolic murmur is also present in mitral regurg, tricuspid regurg, as well as VSD. Okay, all right.
Yes, doctor. Mhm.
So remember these three: mitral regurg, tricuspid regurg, and VSD. All these three have. The first thing is you have to know is they are systolic. Okay, and I have told you again and again how are they systolic. Okay, from this, right? Done. Mitral regurg, right? All right. What about PDA? It's easy. Tell me, yaar.
Machine like murmur.
This continuous murmur in systole diastole both.
Continuous machine, machinery, murmur, right? In both
Systole and diastole.
history and diastole. So now you have remembered the first thing we have discussed in the systole are these murmurs, right? And we also now have systolic murmur from ASD and VSD. The PDA is in both systole and diastole. Okay, done.
Yes.
All right. What about the hypertrophic cardiomyopathy?
Systolic murmur.
So again, systolic murmur. How do you remember this? This is heart, okay, and we have hypertrophy of the left ventricle, okay. So what it does is it is it is causing symptoms like aortic stenosis, okay. The increase or the hypertrophy is blocking the aorta, okay.
Aorta.
So hypertrophic cardiomyopathy blocking the aorta, okay. All right, and aortic stenosis is which type of murmur?
Systolic.
Systolic. Again, the same graph, this and this. This is mitral regurg, this is aortic stenosis, right?
Yeah.
So now you know the concept of hypertrophic cardiomyopathy, and you know aortic stenosis is systolic. So hypertrophic cardiomyopathy is also a systolic murmur, okay? Clear?
Okay.
Now about the sound. So systolic is done, right? But we say in aortic stenosis we have crescendo decrescendo sound, right?
Yes.
Yes.
Why it's crescendo decrescendo? Crescendo means increasing and then decrescendo means decreasing. Because when we have left ventricular pressure going from 80 to 120, the valve is opening and then closing, right? So all this time when the valve open with great pressure, when the valve open with the great pressure, we heard the sound is crescendo. Okay, all right.
Okay.
Okay, but after that the pressure gets decreased backwards, right, in ventricular diastole. Okay, but still the pressure is more than 80, right? But still that's why we hear the sound, but it is now decreasing. Okay, got it? So
Yes.
in aortic stenosis, just remember, in aortic stenosis we have systolic murmur, okay, which is crescendo and decrescendo.
Decrease.
Okay, all right. The same is for hypertrophic cardiomyopathy. Okay, all right.
Yes.
So where do we hear the hypertrophic cardiomyopathy sound? At the
Apex.
left sternal
Left
border, right?
border.
Right.
Yeah.
And where do we hear the aortic stenosis sound?
Right second intercostal.
Right upper, right upper
Right.
sternal border. Now, if you have in a question, we have a systolic crescendo decrescendo sound at right upper sternal border. So it is aortic
Stenosis.
stenosis. So first thing to do is whether it's systolic or diastolic. Okay. Then what's the location? Okay. Done. Done.
Yes.
All right.
Like
And
sometimes these words like rumbling with the
yeah,
click
so
and
yeah, I am not going in
uh,
detail of that because you guys will confuse it. The thing is, I would like you guys to memorize the sounds, okay? Because we forget the physiology behind it, okay? Just the concept to know about the things that are producing similar sound is remembered. That's why I am saying that the hypertrophic cardiomyopathy and aortic stenosis sound are the same, okay? The rest of the things you will forget it, okay? So by going in deeper or more detail, it will the thing will become difficult for you, okay?
okay.
So question, sir. So when they say hollow systolic, does it mean we hear the systolic sound throughout
Yeah,
S1
so
and S2?
no, the thing is crescendo decrescendo. If we have this is in S1, this is S2, so we call this is in systole, right? So if this is crescendo decrescendo means this is increasing, right? And now it is decreasing, okay? The
Okay.
holosystolic is like the same in all the systole, okay? Because the sound is systolic. So only in systole it is increasing and then decreasing, and in the holosystolic is like continuous over the time. Like if you see over to the VSD, right? So we have an open space, right?
Yeah.
So the flow is throughout the systole, right? That's why we
Okay.
have holosystolic. But if you see over here to the aortic stenosis, right?
Yeah.
So the crescendo is due to increase pressure, right? And then
Yeah.
the valve opens,
Yes.
and then the pressure or the sound decreases. Okay. So here we can say the valve opens and then the sound decreases. Okay. That's why in valves you will see crescendo decrescendo. But in VSD, it's holosystolic because we have a path that is constantly or the blood is constantly going through that in whole systole, right?
Okay.
Yeah, what about the aortic regurg? So first tell me, where do we hear aortic regurg?
Left upper sternum border.
Left upper
Right.
sternum.
Right.
Right upper sternum border.
Right upper
It's
sternal body, no?
pulmonic.
Yes, right
Right
upper.
upper sternal is aortic, but I have told you only stenosis. Now again, come again. Both of them are not correct.
Left lower sternal border then?
Okay, left lower sternal border, APT, tricuspid and VST. Come again.
That's mitral.
So, so this
Epic.
so it's aortic regurg. So it's regurging. So it's been coming what downward. So
The
left lower
only
parasternal,
Yes, sir.
right
From
lower
left
parasternal.
left sternal, okay?
to the border, yeah.
We have aortic regurg and hypertrophic cardiomyopathy, okay? All right. So these two are at left sternal border, okay? All
Left
right.
lower, sir. Left lower.
No, left lower is tricuspid. TV. Left lower is TV.
Okay.
Again,
Is this
aortic.
area that's the like fourth intercostal space on the left? This area
Uh,
because the
we can,
tricuspid is in the
yeah,
fifth.
we can say the third, or yeah, the third intercostal, okay? So if this is second, fifth, fifth, so it is somehow over here, okay? This is the rib cage. So it's
Little
here.
above the tricuspid.
So this is right upper, right? Right upper sternal border. Left upper sternal border, right?
Yeah.
Left lower sternal border. Apex. So it's called left sternal border. Okay?
Oh,
Aortic regurg and hypertrophic cardiomyopathy. Okay?
okay.
Now tell me aortic regurg. So we have our location. Now tell me if this is the graph. This is mitral regurg, okay, and this is aortic stenosis and systole, right? Right, guys? So aortic regurg is systolic or diastolic?
Diastolic.
So it is diastolic,
Yes.
okay? Right? Clear?
Okay. Yes.
Can you guys now pick from the simple concept which type of the sound it will be?
Hope so, sir.
Crescendo.
Okay, so we have our location, we have the sound, and we call it diastolic decrescendo, okay? All right, because aortic regurg is happening like this, right? Right? And the sound is decreasing, okay? So what else left? So again to mitral. Now we have mitral regurg, VSD, and tricuspid regurg. All these are
Systolic.
mitral regurg, tricuspid regurg, and VSD. They are systolic, okay? And from VSD you can remember is hollow,
Harsh holosystolic.
right? What about mitral stenosis?
Diastolic.
Diastolic, right? So this is systolic, so this is diastolic, right? So mitral stenosis is diastolic, okay? And we call it opening,
Snap.
snap, or rumble. And the last thing is pulmonic
Can sir you
sound.
please explain this?
Pulmonic sound. What do you want to ask?
This opening snap, can you please explain this one?
Yeah, so
How to
the
remember that?
yeah, I don't know.
Yeah, like you give the clue for almost every of them. Some of them are TV, some of them are like the coastal margin. So how can
Yeah.
we remember this opening snap now?
Yeah, so the wall is stenos, right?
This
The wall is stenos, okay? So when it opens during diastole, it produces an opening snap. Yeah, that's what I can say, okay? Sorry.
okay.
What about pulmonic sounds? So we call it is flow murmurs, okay? And they are not that much high yield because they are occurring with other sounds, okay? Like ASD, VSD, and PDA, okay? So remember the ASD wide split, okay? VSD hollow systolic and machinery murmurs, okay? All right.
Okay.
So yeah, tell me ASD is
Systolic
now tell me the murmur only, okay? Systolic, wide,
split.
big
Wide
split,
splitting of S2.
S2, okay? VSD,
Hollow
Systolic,
systolic,
hard
hollow
systolic,
systolic.
holosystolic.
PDA,
Machine
Continuous
like
machine
left,
like both in
systolic,
systole
diastolic.
and diastolic.
yeah. So I think the last revision, okay. Mitral regurg, tricuspid regurg, and VST. They are the same, okay? So
Systolic.
hollow systolic, right?
Yeah.
And what else? Hollow and systolic, right?
Yeah.
Yeah, and mitral aortic stenosis, crescendo,
Crescendo,
Decrescendo.
Mhm.
crescendo, decrescendo, and mitral stenosis,
Diastolic,
Opening
opening
Oh,
snap,
yeah.
decrescendo.
opening, snap, okay? So the last thing, okay? So if we have systole, now you have to tell me, okay? If we have systole, okay?
Okay.
So, and this is mitral valve, this is aortic valve, okay? So tell me upwards or downwards, okay?
upwards is mitral,
So the
mitral
pressure,
Stenosis.
regurgitation.
yeah, so if the mitral valve or the flow through the mitral valve is like this, we call it is
Rigors.
mitral
Mitral
regurg.
regurgitation.
And why it's occurring in systole? Because the pressures are acting upwards during systole, okay? And during diastole, the atria contracts, right? So the pressure is downward during diastole, okay? So just remember during systole, the pressure, the left ventricular pressure on the mitral valve is acting upwards. So again, this graph is like this, okay? All right.
Yes.
Now aortic. During systole, when we have pressure of the left ventricle or the left ventricle is contracting, the pressure on the aortic valve is upwards or downwards?
What stenosis?
No, the
Downwards.
pressures are
Downwards. No, sir.
downward, right?
I
Right?
mean, towards aorta,
So
right? Is
if
that what you mean by downward?
towards, yeah, towards aorta. And if
Aorta.
the valve is stenosed, so we will have murmur, okay? So mitral regurg and aortic stenosis. Okay. Thank you guys. Thank you so much, guys. That's all for
Yeah,
today.
thank you.
Thank you,
Thank you,
doctor.
Vedant. Thank
Thank
you
you.
for a great explanation. Thank you.
Thanks a lot. Hope you guys have understand some of the sounds. It's a bit of a difficult topic for the students, okay? Yeah, so take care. Bye bye.
Bye bye, sir. Thank you.
You're welcome.